Hypertensive disorder of pregnancy. Hypertensive disorders of pregnancy. Objectives at the end of this class, you will be able to define hypertension, classify hypertension, diagnose each type of hypertension, manage each type of hypertension. Introduction. Hypertension is defined as a blood pressure greater than or equals to 140 per 90 millimeter hydrogen on at least two occasions at least 6 hours apart, a maximum of a 1 week period. PIH are an important cause of severe morbidity, long-term disability, and death among both mothers and their babies. It affects 10% of all pregnant women around the world. The majority of this is due to pregnancy eclampsia or PE and eclampsia. Pre-eclampsia and eclampsia are avoidable through the provision of timely and effective care to the woman presenting with these complications. Introduction. Severe hypertension increase the mother's risk of heart attack, cardiac failure, cerebral vascular accidents, and renal failure. The fetus and the neonate also are at increased risk from complications such as poor placental transfer of oxygen, fetal growth restriction, preterm birth, placental abruptions, stillbirth, and neonatal death. However, the pathogenesis of preeclampsia is only partially understood, and it is related to disturbances in placentation at the beginning of pregnancy. Types. For clinical purposes, women with hypertension may be classified into one of the following categories. These are 1. Gestational hypertension. 2nd, preeclampsia. 3rd, chronic hypertension. 4th, superimposed preeclampsia. 5th, eclampsia. 1. Gestational hypertension. It is an elevated blood pressure, first detected after 20 weeks in the absence of proteinuria or other features, or SX per SY of PE, preeclampsia, or pre-existing hypertension, which return to normal within 6 weeks after delivery. The 2nd, preeclampsia. The syndrome of new onset of hypertension and proteinuria after 20 weeks of gestation in a previously normotensive woman. Incidence. Preeclampsia occurs in up to 7.5% of pregnancies worldwide. There is 2 types of preeclampsia. Two types, mild and severe. Preeclampsia. Severe. When severe hypertension, severe proteinuria, or sign or symptoms of end organ injury are present, such like fetal growth restriction, oligohydramnios, seizures, or eclampsia, pulmonary edema, renal failure, and HELLP syndrome. In the absence of any of these findings, it is mild preeclampsia. Proteinuria is concentration of 1.1 gram per L protein or more per 1 plus or 0.3 gram or 300 milligram in a 24 hours. In the absence of proteinuria, the syndrome of preeclampsia should be considered. Persistent cerebral symptoms, epigastric or RUQ, pain, plus nausea or vomiting, and IUGR. Abnormal lab tests such as thrombocytopenia and elevated liver enzymes. Edema is no longer recommended as a diagnostic criterion for preeclampsia. Criteria for severe preeclampsia. About 25% develop one or more of the following findings. 1. Severe hypertension. Systolic blood pressure greater than 160 mmHg or diastolic greater than or equals to 110 mm hydrogen. Severe symptoms and severe signs and symptoms. Persistent and severe headache, visual abnormalities, photophobia, blurred vision or temporary blindness. RUQ, epigastric pain, nausea, vomiting, oliguria, that means less than or equal to 400 ml per 24 hours. Dyspnea, retrosternal chest pain or pulmonary edema, fetal growth restriction, oligohydramnios, and altered mental status. 3. Laboratory abnormalities, hemoconcentration and hemolytic anemia, thrombocytopenia or less than 100,000 per micro L. Elevated serum creatinine concentration greater than 1.3 mg per dl. Elevated liver enzymes, that means twice the upper limit of normal. 3. Chronic hypertension. Hypertension present before the pregnancy or that is diagnosed before the 20th week of gestation, or hypertension that persists for greater than 42 days postpartum or which does not worsen appreciably during pregnancy, persists after delivery, and use of antihypertensive before pregnancy. 4. Chronic hypertension with superimposed preeclampsia. The diagnosis is based on one or more of the following findings. 1. Development of new onset proteinuria, urinary protein excretion of 0.5 gram per 24 hours. Specimen in women with hypertension and no proteinuria before 20 weeks, or in women with hypertension and proteinuria before 20 weeks. Severe exacerbation in hypertension. Development of sign and symptom or HELLP syndrome in women with hypertension and proteinuria before 20 weeks. Etiology of preeclampsia. Risk factor for preeclampsia. Age less than 20 years or greater than 35 years, null parity, multiple gestation, high deform mole, diabetes mellitus, chronic hypertension, renal disease, collagen vascular disease, family history of preeclampsia. Risk factors. Past history of preeclampsia increase the risk in a subsequent pregnancy sevenfold compared to women without this history. The severity of preeclampsia strongly impacts this risk. Severe second trimester subsequent pregnancy 25 up to 65%. Mild first trimester pregnancy subsequent pregnancy 5 up to 7% of second pregnancy. Hypertensive first delivery less than 1% of second pregnancy. First pregnancy null parity. The reason is unclear. One theory suggested that having limited recent exposure to paternal antigens, which may play a role in the pathogenesis of the disease. Risk factor. A family history, first degree relative, suggesting a heritable mechanism in some cases. The father of the baby may contribute to the increased risk, as the paternal contribution to the fetal genes may have a role in defective placentation and subsequent preeclampsia. Pre-existing medical condition. Pre-gestational diabetes related underlying renal or vascular disease, high plasma insulin levels or insulin resistance, and blood pressure greater than or equal to 130 per 80 mmHg at the first prenatal visit. Risk factor. Twin pregnancy. The risk increase with number of fetuses. Example, triplet pregnancy triples the risk than twin. Advanced maternal age. Maternal age greater than or equal to 40. Older women tend to have additional risk factors such as DM and chronic hypertension. Pathogenesis involves both maternal and fetal placental factors. Abnormalities in the development of the placental vasculature early in pregnancy, weeks to months before development of clinical manifestations of the disease. These abnormalities can result in placental underperfusion and possibly hypoxia and ischemia, which leads to release of circulating anti-angiogenic factors or tyrosine kinase, soluble endocrine, and other substances. Continues. This substance causes maternal systemic endothelial dysfunction, increased vascular permeability, vasoconstriction, activation of coagulation system, microangiopathic hemolysis, finally resulting hypertension, proteinuria, and the manifestation of preeclampsia. Theories associated with pathophysiology of preeclampsia. 1. Abnormal thromboplastic invasion. 2. Vascular endothelial damage. 3. Genetic predisposition. 4. Immunologic phenomena. 1. Abnormal thromboplastic invasion is the development of uteroplacental vessels proceed in two waves or stages. The first wave occurs before 12 weeks post-fertilization and consists of invasion and modification of spiral arteries up to the border between deciduous and myometrium. The second wave between 12 and 16 weeks and involves some invasion of the intramyometrial segments of spiral arteries. Continues. The remodeling by these two-phase invasion converts narrow lumen muscular spiral arteries into dilated, low resistance, low pressure, high FBW uteroplacental vessels. In preeclampsia, thromboplastic invasion is restricted to deciduous segment of uteroplacental arteries. No myometrial spiral arterial invasion. The first wave of endovascular thromboplastic invasion may be incomplete, and the second wave does not occur. As a result, the deeper segments of the spiral arteries are not remodeled. Continue. The reason is that endovascular thromboplastic invasion progresses normally in most pregnancies, but abnormally in others is unclear. One theory maintains that maternal antibodies directed against paternal antigen on invading thromboplastis are necessary to shield those antigens from recognition by decidual natural killer cells. Endothelial damage results in red endothelial production of PGI2 or prostacyclin, a potent vasodilator and inhibitor of platelet aggregation. Second, vascular endothelial damage. Placental ischemia leads to production of placental factor. Mechanism: decreased placental oxygenation triggers the placenta to release an unknown factor into the maternal circulation. This circulating factor is capable of damaging or altering the function of maternal endothelial cells. In many cases, reduced placental oxygenation may be explained by maternal vasculopathy or vascular disorder such as chronic hypertension, renal disease, collagen vascular disease, and in others by abnormal placental mass. That means multiple pregnancy, diabetes, deform, mole. Continue. Elevated intravascular pressure combined with damaged vascular endothelium result in movement of fluid from the intravascular to intravascular space, leading to edema in brain, retina, lung, liver, and subcutaneous tissue. Hypertension and glomerular endothelial damage. That is proteinuria. Cerebral edema, vasoconstriction, and capillary endothelial damage to hyperreflexia, clonus, convulsion, or hemorrhage. Hepatic edema and or ischemia, hepatocellular injury and elevation of serum transaminases and lactate dehydrogenase or LDH levels, stretching of Gleason's capsule, and RUQ or epigastric pain. Intravascular fluid loss across damaged capillary endothelium in the lungs, resulting in pulmonary edema. In the retina, vasoconstriction and or edema, vascular disturbances, retinal detachment or blindness, movement of fluid from the intravascular space into the subcutaneous tissue, resulting in non-dependent edema. Third, genetic predisposition. Genetic conflict theory. Fetal and maternal genes conflict each other to control nutrient transfers to the fetus. Immunologic factors. The formation of blocking antibodies is impaired for placental antigenic activity. That means previous pregnancy has immunologic effect. Large area of antigenic site. Multipara with a new partner is at risk. Diagnosis. History. Age parity. G per ANC follow-up. Presence of cerebral symptoms. Risk factor. Medical history. Socioeconomic status. Physical examination. General appearance. Blood pressure should be taken appropriately. Look for pallor, jaundice, tongue bite, basal crepitation, REQ or epigastric tenderness, hepatomegaly, obstetric examination, pelvic examination, edema, DTR, investigation, hematocrit, platelet count, urine analysis, quantification of protein excretion, serum creatinine, liver function test, serum LDH level, obstetric U/S. Post-diagnostic evaluation. The purpose of the post-diagnostic evaluation is to determine the severity of the disease and assess maternal and fetal well-being. The minimum post-diagnostic lab or imaging evaluation should include platelet count, serum creatinine, serum aspartate amino transferase, AST 10 up to 40 U/L or alanine amino transferase, ALT 7 up to 56 U/L, LDH 140 up to 280 U/L. Obstetrical U/S. Fetal weight, amniotic fluid volume, fetal assessment. That means biophysical profile or non-stress test. That means fetal heart rate, fetal tone, fetal breathing, fetal movement, and amniotic fluid. Management of hypertension in pregnancy. 1. General measures. Admit the patient urgently if not done before. Manage in left lateral position. Set up IV line and infuse fluid to replace estimated loss. That means bleeding, vomiting, diarrhea, sweating. 500 ml in first 1 per 2 hours. Avoid fluid overload since women with severe disease are at risk of pulmonary edema. Place an indwelling catheter to monitor urine output and proteinuria or UOP should be at least 30 ml per hour. Prepare equipment for conversion. Management at bedside. That means mouthpiece, airway, suction equipment, mask and back oxygen drugs. Management. Never leave the patient alone. If convulsion occurs, aspiration may cause disease. Observe fetal signs, fetal heartbeat, and reflex early. If occur, withhold fluids and administer a diuretic furosemide 40 mg IV stat, anti-emetic for nausea and vomiting, anti-pain if RUQ pain. 2. Stress reduction. Component of stress reduction includes Quite isolated room, planned management protocol, clear explanation of the management plan to patient and the family, consistent, confident in the team approach. 3. Anticonvulsant therapy. That means Seizure prophylaxis should be instituted in all eclamptics during labor and continued for 12 up to 24 hours after delivery or last convulsion. In all severe preeclamptics during admission, continued during period of evaluation and observation. Not be careful. It is difficult to predict who will seize. It is not directly related to degree of hypertension or level of proteinuria. Blood pressure is not a reliable predictor of the risk of seizures. Some may seize with blood pressure of 140 per 19 mmHg. Magnesium sulfate, vice versa, other anticonvulsants. Magnesium sulfate is first-line drug of choice for the prevention of eclampsia in preeclampsia and treating convulsions in eclampsia in preference to other anticonvulsants. Effective for prevention of recurrent seizures than phenytoin, diazepam, or lytic cocktail. That means chlorpromazine, promethazine, and pethidine. Magnesium sulfate is usually initiated at the onset of labor or induction or prior to cesarean delivery. Loading dose of magnesium disulfate. Magnesium sulfate 4 gram as 20% solution, IV given over 5 minutes. Mix 8 ml of 50% magnesium sulfate solution with 12 ml of D5W or normal saline to make 20% solution. 10 gram of 50% magnesium sulfate solution. 5 gram in each bottle as deep IME injection with 1 ml of 2% lignocaine. Ensure that aseptic technique. Warn the woman that a feeling of warmth will be felt when magnesium sulfate is given. If convulsion recur for eclampsia after 15 minutes, give 2 gram magnesium sulfate or 50% solution IV over 5 minutes. Maintenance dose. 5 gram magnesium sulfate or 50% solution plus 1 ml lignocaine 2% IM every 4 hours into alternate buttocks. Continue treatment with magnesium sulfate for 24 hours after delivery or the last convulsion, whichever occur last. Before repeat administration, ensure that respiratory rate is at least 16 breaths per minute. Patellar reflexes are present. Urinary output is at least 30 ml per hour over 4 hours or 100 ml per 4 hours. Not be careful. Respiratory rate, DTR, and UOP should be monitored Q1 hour. Maintenance. Withhold or delay drug if respiratory rate fell below 16 breaths per minute. Patellar reflex are absent. UOP fell below 30 ml per hour over preceding 4 hours. Keep antidote ready in case of respiratory arrest. Assist ventilation. Mask and bag anesthesia approaches intubation. Give calcium gluconate 1 gram or 10 ml of 10% solution IV slowly to recognize the effects of magnesium sulfate. Diazepam. If magnesium sulfate is not available, diazepam may be used, although there is a great risk for neonatal respiratory depression because diazepam passes the placenta freely. Long-term continuous IV administration increases the risk of respiratory depression. Loading dose. Intravenous administration. Diazepam 10 mg IV slowly over 2 minutes. If conversion occurs, repeat loading dose. Diazepam maintenance dose. Diazepam 40 mg in 500 ml IV fluid, normal saline or ringer lactate. Maternal respiratory depression may occur when dose exceed 30 mg per 1 hour. Assist ventilation, mask, back, anesthesia, apparatus, intubation if necessary. Do not give more than 100 mg in 24 hours. Rectal administration when IV access is not possible. The loading dose is 20 mg in a 10 ml syringe. Remove the needle, lubricate the barrel, and insert the syringe into the rectum to half its length. Diazepam. Discharge the content and leave the syringe in place, holding the buttocks together for 10 minutes to prevent expulsion of the drug. Alternatively, the drug may be instilled in the rectum through a catheter. If convulsions are not controlled within 10 minutes, administer an additional 10 mg per hour or more, depending on the size of the woman and her clinical response.